Good evening, everyone. Welcome to our YouTube channel, to our live stream. As was promised, today we are going to do live Q&A. As a good tradition, we have collected some questions. We actually started our promotion of this live on Instagram page, and we asked our audience about questions that they would like to discuss, and we have collected a lot of nice questions. So basically we're going to start with this, and guys, join us, and you will be able to also to ask questions right now, and I will be more than happy to reply to all of your questions, to give you as much as possible from the bottom of my heart. Okay, so I think that it's just 2 minutes after the live announcement. Maybe not all people join, so we will wait. Somebody, just before we wait, let me know where are you from, which country are you from. And the good thing also, this is what I didn't ask you before, but I would like to ask right now. Please write down your clinical experience. Like you graduated, for example, I don't know, 2015 or 2025, you just fresh graduated or whatever. I would like to see the country where you're from and also your clinical experience. That will help me also to design actually some presentations, some topics, because we plan to continue on our YouTube channel to give you more content. As you know, we have this nice, like you say, the not episodes, but the good projects. I would say they are projects like a dental tips, BG dental tips, short videos about dental tips and tricks. And we started recently, not very long time ago, we started on our YouTube channel another project which is clinical videos. So this project is without comments, just pure clinical content filmed from the microscope, step-by-step procedures and so on and so on. So once you will tell me your clinical experience, we will see all your answers there. It will help me to really design some other projects, or maybe I will do some episodes to the BG dental tips for let's say fresh graduated dentists or for experienced dentists and so on and so on. This is what we are going to do with your help. Okay, so let's start. Actually, I think that we can start. We have the first question that I'm going to discuss. The first question was tree shape, because I'm using I use Prime Scan from Dentsply Sirona, but at the end of the day, tree shape, Prime Scan, some other devices like Medit or 8 Teeth and so on, they are really good. Then the new latest intraoral scanners, they are very good. The algorithms of scanning is good, the precision is nice, less distortions, the depth of the scanning is really good. So the tips and tricks for veneer prep scanning will be related not to tree shape, but to the, let's say, digital workflows and so on. So there is no actually secret here. The first thing, if you would like to make a finish line visible for your dental technician, you have to get the very good finish line, first of all. So your preparation has to be fine. Your preparation has to be precise. So you have to spend time to make your preparation really good. And this is not just about finish lines, okay? Because many people, they really think about finish lines. We need to make a finish line. My dental technician needs finish line. I would like to check my presentation fit. Sorry, not presentation fit, but preparation fit to the finish line. And everything is about finish line. But the finish line is not a keystone of the preparation. It is an important element of design of preparation for sure, but the finish line is just an element. The most important is not finish line. The most important is the space for the restoration, the aesthetic transition, the insertion path. These three things are super important, okay? So if you do your preparation well, you follow planes, you get your transitions, you get your insertion paths, you give to your dental technician enough space, then you will get everything superiorly nice. Then what's next? The next is to scan your finish line and the entire design properly. For this, we are speaking about retraction, because in a veneer cases, I think in most of the veneer cases, we do our preparations inside the sulcus. Okay, so it is intrasulcular preparation or intraclavicular preparation, we can call it like that. So when you do your preparation inside the sulcus, we usually use retraction cord during this process, right? So you place retraction cord gently. We were speaking about this recently. I think we have some videos about proper retraction. If you missed them, you just need to go to our YouTube channel and just to check it, and you will find these videos about retraction principles, step-by-step, algorithms, protocols, and so on. So anyways, you place your retraction cord, okay? Then you move your finish line down the sulcus. So that's fine, that's good. It has to be like that, okay? Then during preparation inside the sulcus, what you have to follow? You have to be gentle with the gingiva, because if you will use coarse bores or medium grit bores and you will use turbine, for example, you will touch the gingiva will be bleeding, okay? So that's what may happen. So my intake here is to use electric motor, increasing handpiece, and red diamond bore. When you do your preparations inside the sulcus, you relocate your finish line inside the sulcus, you have to work with a fine grit bore, electric motor, low speed, and then even if you will touch gingiva, I think the gingiva will not bleed. Let me just show you one of the episodes from another presentation, so you will be able to see that. So take a look. We here have the preparation. Scanning. This is why I'm showing you that. I spend that much time to explain these things, because these are obvious things, they are classic conventional things, but they are super important. It's more important than the brand of the scanner, for example, okay? Because you can have the best scanner in the world, which if it exists, okay? But your preparation is rough, the gingiva is bleeding, and then what you will have is a final. You will have a good scan of bad thing. Good scan of bad prep. That's interesting, right? Okay, so preparation has to be good. Soft tissues, happy. Meeting bore, another aphorism. The gingiva has to be happy during meeting with the board. That's very philosophic. I think we will have to note this somewhere. Okay, anyways, so what's next? After you finished your preparation, okay, retraction cord, everything is good, no bleeding, everything done. Then what you will do? Then you will check if finish lines are visible. So you clean everything, you dry everything, then you just take a look with your eyes or with your magnification, with your loupes, microscope. You just check if you can see all your margins exposed. You scan. You're happy. You scan. But if somewhere the finish line will be hidden because of the deep preparation and the gum is over it, or sometimes it happens in a deep preps, the gingiva can go really above your margins. After you finish your preparations, it takes time, so the gingiva can go above the finish line, and then you will definitely have problems with the scanning. You will be not able to scan the finish line because it will be very hidden under the gingiva. That's the problem. Okay, so in this case you will have to go with another retraction. Okay, so additive retraction, additional retraction, because the first retraction we do during the preparation. So that's the first retraction cord. Okay, so it stays during preparation, and then after you finish, you check everything. And then if you see that somewhere the finish line is covered, then you do what? You will do additive retraction. So now let me show you another question from the Instagram. So I will answer this one. What is better, for gingival retraction, cord or paste, and why? Because this actually question is connected to the first question about tips and tricks for the scanning, because retraction influences the appearance of the finish line, how clean it is, how visible it is, okay? So that's the continuation. So what I will do, if coming back, if I finish my prep and I see that somewhere finish line is covered, I will use retraction paste, okay? I will use retraction paste. So this is the short video demonstrates you how we use retraction paste. Okay. Just let me just make a small pause and take a look on the teeth that are not covered with the retraction paste yet. So we have the retraction cord. We can see margins, but somewhere they are really a little bit covered by the gingival. Not everywhere, but just tiny somewhere. Okay. So this is the case, which for me is indication to use retraction paste rather than second retraction cord. Okay. So in this case, we use retraction paste. We inject it into the sulcus over the first retraction cord. Usually I do it this way, because you can also use retraction paste without retraction cord. But for me, the combination of retraction cord and retraction paste is one of the best. In the cases where the finish line somewhere is hidden by the soft tissues. Okay, so this is the way. So we do this, then we keep retraction paste for about 3-4 minutes. Okay, then we will rinse it, and then we will dry everything. You have to see every single margin equally exposed. Everything has to be dry, and then you go with your scanning. Okay, so that's the way. But if after your preparation the margins are covered with a gingiva in many regions, many areas, then in these cases I prefer to go with second retraction cord. Okay, so I place the second retraction cord over the first one. So the second retraction cord usually is one size bigger. It can be impregnated. You can actually use also hemostatic gel, for example, to put on the gingiva where the bleeding is. Then you place your second retraction cord. Then you will have to wait 5-6 minutes. Then after that, you rinse everything, you remove second retraction cord, you dry everything, all margins have to be visible. The second retraction cord actually gives you lateral retraction, and then you scan, okay? So that's the secret of good scans. Everything has to be visible without scanning, before scanning, all margins, all transitions. Everything has to be dry. That's also important because, you know, the intraoral scanner can scan when the saliva is bleeding, it's so on and so on. But at the end of the day, everything has to be pretty same as for impression. Dry, filled is the good environment for a good impression. The same with the scan. So then you scan, you have everything good. Then the protocols of scanning are different depending on the scanner, I think. But what I know is that you can use so-called universal scanning process, like continuous arch technique, when you place the scanner to the occlusal surface on the last tooth and you go all the way to the last tooth on the other side without interruption. Okay, you can do it from the palatal side a bit or from the buccal side a bit. You go all the way, so that's the core, and then you can scan other parts following your initial scan. So the initial scan is like a framework, okay? So let's say it's a framework, so you can go down with a scanner, grabbing other parts of the teeth which are not scanned. So that's actually the secret, or let's say the protocol of good scanning and good tips and tricks to make finish line clear to the lab. Okay, so that's the thing. You have to have a good finish line itself from the very beginning. At least, by the way, the size matters depending on the scan. But let's say the optimal or minimal 0.2, 0.3 millimeters, it's okay. But 0.4, perfect. Okay, so then it has to be homogenic, smooth, clear, exposed, dry, and then you scan and everything will be fine. Okay, good, very nice. So let's do another question. Let's go for another question. if I want to replace a newly placed composite, how can I be sure it completely removed? Okay, that's interesting question. That's good question. But before I answer this question, I would like to go back to the previous one and show you that, okay? So if you want to learn how to do your perfect preparations, how to make your dental technician happy, by the way, because if you know the protocol, if everything works perfect, your dental technician will be happy. So we have one of the best course in the world, I can tell you, because you can see how often we run this course, and usually they are fully booked. So sometimes few times a month, and we do this course for international colleagues from all over the world. 2 days course about preparation, veneers, crowns, overlays. We speak about retraction, we speak about instruments, we speak about protocols, we speak about indications, we speak about modern principles, materials, and so on and so on. So you can see the dates. You always can find more information on our webpage, which is belograd.com, and we will be happy to see you here in Prague to share with you everything we know about preparations and even more. Okay, good. So let's go back to this question. So we have if I want to replace a newly placed composite, how can I be sure it completely removed? Okay, so I will show you one thing. I will show you a video where you will be able to see one of the most efficient device, I would say, or add-on to your magnification, which is called fluorescent filter. Okay, so here we do a preparation for the crown. By the way, look, red diamond bore, electric motor, increasing the handpiece, no bleeding. Look, we touch the gum, no bleeding. It will be a little bit, but just imagine if you have a turbine, for example, what will happen with the gum? It will be a Bloody Mary. Everything will be like a Baba Hanush. Okay, so this is the fluorescent filter, fluorescent light. It helps me to identify composite. I don't want to have margin in composite, the very cervical margin, finish line. I don't want to have it in composite. I want to have it in the tooth. So the fluorescent light, fluorescent filter really helps me to see that. So the fluorescent filter can be integrated into your microscope. If you don't have microscope, what you can use to have this fluorescent light, you can buy a lighter, fluorescent lighter. You can buy it on AliExpress, for example, and you can use that because it will help you to see the composite. Okay, so this is one thing. Another thing I would like to ask you: why do you need to remove it completely? As on the question here we have, I want to replace a newly placed composite. That's the question. So why do you need to replace it? If it's newly placed, as I understood, or actually it has to be like that. So if you do your composite restoration, direct, semi-direct, indirect, there are different types of composite restorations and different techniques to work with composite, by the way. So many. It's not just freehand or matrix based. There is a copy-paste technique based from the copy from the model, copy from the tooth, semi-direct. Part of the restoration goes inside the patient's mouth, part of the restoration is performed outside. Then you bond it. Then you have indirect and so on. So that's super interesting. Composite, by the way, one of the best materials in terms of flexibility. It gives you so many different techniques and a huge range of applications that sometimes we get dizzy. But anyways, the question is, if you place the composite, it has to be done with a rubber dam. Okay, you place rubber dam, maybe, probably, you have to. Then you do your bonding protocol, carriers free, you remove carriers. Then you do bonding protocol, following step-by-step instructions, how to make the hybrid layer fine, how to get down with stress. I mean the polymerizing stress, not the psychological stress. So then you use composite properly. You do test of adaptation test. By the way, another question I would like to ask you before I will continue. I would like to ask the audience who knows about adaptation test working with composite. So when you do composite restoration direct, there is an adaptation test. Who knows about this adaptation test? And if you know about the adaptation test, please comment. What is that? That's also interesting, but that's super important, by the way. Adaptation test is super important. But let me go back. So when you place the new composite, and then I don't know why you need to remove it or redo it or correct it or whatever. So the question, why do you need to replace it completely? You can really keep some of the composite on the tooth, because really it's difficult to drill out the composite from the tooth completely. It's difficult, especially if you have a very nice color matching, okay? So fluorescent light will help you for that. The dry preparations with a low speed, dry with the air spray, it also helps you to see the composite, to see the tooth. But at the end of the day, it's really difficult, and it's pretty invasive, because trying to remove completely the whole composite, you may get, the composite that is bonded well, you may get some of a reduction of the tooth structure. So this is what you have to know. You can keep perfectly bonded composite on caries-free surface, stay in the tooth. So you don't need to remove it completely. So you can do your another restoration over that one. There is a protocol how to do this, how to bond to composite, but at the end of the day, it's possible to keep this composite partially on the tooth. Okay, but if you want to remove it, so fluorescent light will help you for that. Then some kind of dry preparations will help you to do that better. But my friends, if you want to make your composite restorations perfect without necessity to redo them, here we go. No, that's not this one. This one. Composite and rub and course. Okay, so during this course, 2 days, we do direct restorations, indirect, semi-direct, rub-and-dam isolations, bonding protocols, layering protocols, frontal teeth, back teeth, tooth wear cases, trauma cases, everything. Okay, so everything you need to know about composites, we can give you ready-made solutions during these 2 days, and you will be completed. Okay. So please welcome. We run this course rarely. Comparing to prep course, you can see the big difference. So we have just one date. Another one will be somewhere in the end of the year, I think. So more than happy to see you if you would like to level up your composite restorations and the rub-and-dam isolation as well. Good. So let's go to another question. So we have another question, which is also connected to composite restorations and so on, semi-direct and so on. Discuss 3D printed veneers as a middle option between composite and ceramic veneer. 3D printed veneer. Actually, 3D printing and technologies becomes more and more popular. They become cheaper, more accessible. And the new resins arrive. New resins, hybrid resins, the resin reinforced with some zirconia, some glass or ceramic particles inside, and so on and so on. So many manufacturers, they start to do more and more resins that you will be able to use for final restorations. Because actually, before that, we mainly used 3D printers for models, for sure, for the guides, the navigations, and so on. But we also used 3D printers for temporary restorations, right? But nowadays we have a good possibility to do so-called permanent restorations using specially designed resins for that. My opinion. I used actually some of the printed restorations, but I didn't use them as final ones. I used them as long-term provisionals in the functional cases. For example, when we do full mouth rehabilitation, then we do provisional restorations to test drive occlusion, to do some corrections if needed, and so on. So we used also some 3D printed options. And in time, after a month or two, I was not very happy with the surface, honestly speaking. I don't remember exactly which material I used. Maybe that the problem comes from the material, probably. Okay, so I'm not saying that the 3D printed veneers or restorations are bad. Maybe the material that I used was not perfect enough for that. but I didn't find this solution for myself, let's say, the one that I will go for. But again, we just had the IDS finished in March, and there were so many products, 3D printed products for permanent restorations. So I think that some of them now they can be very, very good. And the thing is that the 3D printer allows you to do relatively easy these kind of restorations, the time wise, the expenses wise, so everything becomes more and more accessible. So in general, let's say if we speak about the 3D printed veneers as option, middle option between composite and ceramic, I will say why not? Why not? You can go for that. Why not? At the end of the day, not many patients can afford ceramic veneers. Not many patients can afford composite indirect veneers or direct veneers, because if you do direct composite veneers and you do them in a really advanced way, it takes time. It's not like a half an hour and you have everything restored. Even though the material is easy, I mean the composite itself, it's easy accessible. You have your flat plastic instrument, you have brush, you have light curing lamp, you have composite, you go. But from another perspective, composite is very technically sensitive material. If you would like to make your restorations long lasting with direct composite or indirect composite, you have to know how to work with the composite properly. So it takes time. If it takes time, it cannot be cheap, because at the end of the day, the value of your time and the value of the material itself is different. Okay, so but 3D printed veneers may help you to save some time, and can be a very good option in, let's say, low-cost cases where patient, how to say, cannot afford ceramic restoration. So why not? Why not? Yeah. So we have a colleague, Cobra Karen. He's saying that he uses 3D printer for permanent restoration, and it is very sensitive to the material you use, for sure. As I told you, the material that I used maybe was not very good, but nowadays we have more and more. We have like even zirconia materials to be printed. At the end of the day, that resin with some percentage of zirconia, and I think that the surface is pretty resistible and durable. So again, why not? Why not? I think that the future is for that 3D printing. Milling process is still a best option, I think, in terms of the precision, in terms of the material selection. Again, material selection, okay, and the long-lasting restorations. But at the end of the day, once we will have same as ceramic or same as zirconia that is milled, but for printed, that will be the end of the milling era. So everybody will forget about milling machine, like we forgot already frames when we take X-rays, for example, right? Okay, good. Let me check another question that we have here. What do you think about zirconia veneers? Okay, so that's another hot notch topic. Nowadays, many people, they start to use zirconia more and more for veneers, for minimally invasive restorations, or let's say for non-retentive restorations, okay? Because crown also can be minimally invasive, because if you will do, let's say, modern crown with the modern principles of preparations, comparing to the old types of PFM crown preparations, it will be really big difference. So we can say now crowns are also minimally invasive. But anyways, veneers made by zirconia. Okay, so these are non-retentive restoration, which means you have to bond it, right? Because if you have veneer, like type 1, for example, I hope that you know what is type 1 veneer. So anyway, even if type 3 veneer, the thing is that the veneer has no retention, so you have to bond it. And not very long time ago, we didn't have, let's say, proved data about bonding to zirconia. Nowadays, thanks to Marcus Blatz, thanks to other colleagues involved into study and research for the zirconia materials, we have good protocols to bond to zirconia, okay? APC protocol, for example, by Marcus Blatz. And you can bond to zirconia. That's another thing. Another thing which is, I think, unique, but we need to test it, to study it. There is one brand of zirconia, and the company producing the zirconia material, they have a special connector. It's a special spray that your dental technician uses inside the internal intaglio of the zirconia before sintering, before you go to sinterization, okay? So this spray is actually a super micro thin layer of lithium disilicate. So basically this lithium disilicate layer will be impregnated into the zirconia before sintering, and at the end you will have on the internal intaglio of your zirconia restoration the thin layer of the lithium disilicate, which you can use for good and stable bonding, okay? You can edge it with hydrofluoric acid, you can use silane, and then you bond it with a resin cement, okay? So that's perfect, I think, right? But we need really to research, to study the stability of the connection of this micro layer of the lithium disilicate over the zirconia. If it will be really durable and long lasting, so now everything will be resolved, so you can bond to this type of restoration and so on. Zirconia gives you a lot of let's say varieties and options. The zirconia is very strong, we know that, but the question is really if we really need to have that strong material that is stronger than enamel. That's one thing, okay? So zirconia is not biomimetic comparing to glass ceramic, so if you follow the biomimetic principles. But we have a very good materials, zirconia materials, like a multi-layered zirconia materials, translucent zirconia, which is really aesthetic, okay? And the thing is that most of zirconia materials, they do not have this typical gray appearance like some of lithium disilicate materials, okay? So this is what can be a benefit, I think. The color-wise, the chroma, the hue, the value of zirconia is very good. Yes, so this is what is my intake. So I think they're okay. I think that more and more we will start use zirconia veneers more and more. Personally, I don't use zirconia veneers. Yeah, I have only one case, one lateral incisor only, because the results that I have with a glass ceramic like lithium disilicate or lucite or feldspathic, really I'm happy with these results. So I don't really feel necessity to change the material that gives me results. So this is my intake, and I really know how the bonding stability looks like to the glass ceramic. With the zirconia, we have studies, we have also some experience, some opinions, but at the end of the day, I want, to see that the true clinical results are similar that I have with a lithium disilicate, for example. And then, but you again, if you want, now everybody can do that. Okay, so we have another question. Thank you, doctor. I have attended several of your online courses and they have been incredibly helpful to my practice. I'm really happy to hear this, and imagine if you will come to our hands-on course. You see that if how much information we share on our YouTube free of charge, then we also share information on our online courses, online masterclasses. You can find them, by the way, for other people who don't know. You can find our online masterclasses on our webpage. You go to belograd.com, and then there is the folder online, and you can see a lot of different topics and nice online masterclasses that you can watch anytime you want. So, but on our offline and hands-on courses, even more tips and tricks. So I would like to ask your current protocol for gingival retraction when taking gingival impression. Do you still use the double core technique and remove the second core before scanning? Actually, I replied this question already at the beginning of this live stream, so probably you missed it. So you'll be able to go back and to see the answer. Good. And also, do you prefer digital or conventional impression for anterior teeth? Thanks. So that's another question. I prefer the digital. So nowadays I do only digital. I don't take impressions, silicone impressions anymore. I think more than 6 or 7 years. We have a protocol of scanning, and also what is important in the digital workflows is to have a dental lab with a very precise digital protocol. So you have to be digital, your dental lab has to be digital, and you have to complement each other. And then digital protocols will work very well. What do you think about veneers milled with prime mill? Can they give us a good result and aesthetics? That's the question from Dr. Benan. We have we don't have prime mill, but we had MX XL, I think, and MX X5 from Dentsply Sirona. So MX XL is just before prime mill. So it's like let's say old, less advanced version of the prime mill. And our lab actually milled a lot of veneers using that machine. So we were happy with the result. The result give the machine that is itself. It's important for sure, but at the end of the day, the vital look of the restoration is given by dental technician, by the human touch. We call it the human touch, and then everything becomes a magic. Okay, if the question is related to the chair side, like for example, you have your patient, you prep, you scan, then you design yourself quickly, then you mill. So that's actually another question, because theoretically you can also make a very nice restorations if you know how. So basically you need to take on your side dental technician work. If you know how to do finishing, polishing, maybe micro layering, maybe staining, maybe some cutback and so on. If you know about that, if you really experience in that, you can have a really good results. But if you just rely on the machine, you can have results, but the thing is that what do you really put on the good result and aesthetic, because aesthetic is subjective. So some people will say the chewing gum veneer style is aesthetic, but somebody will say it's not natural. Okay, so that's the thing. If you would like to speak, if we speak about natural looking veneers with a nice surface, nice texture, you still have to do some handwork. If you know how to do this, the result will be good. If not, unfortunately. Okay? Good. So let's go to another question. Now we have another question. Let me just check. I would like to ask, in which clinical situation do you prefer vertical preparation over horizontal preparation? My friend, your name is, I cannot really read your name, to be honest. Can you just write down what's your name? Like English version of the name. John, Smith, Bob, maybe, because I just want to have your name, to communicate with you using your name. So the question is about vertical preparation and horizontal preparation. I prefer horizontal preparation in all cases except cases where the biologic width is violated. For example, you have deep caries, right? Or you have old restorations, very deep preparation. PFM crowns, this is very typical. We have patients with the PFM crowns, and these teeth were prepped super deep, super subgingival, so the gingiva is red and blue at the same time. So the very bad conditions of the soft tissues. So for that type of cases, the vertical preparation will be super nice. Also, when you have recessions, you can, depending on the case, because we still have the surgery, okay? But when you have recessions, you can use vertical preparations to get optimal results. There is a technique. Actually, vertical preparation is just like a very general name, and we have a lot of variations of the vertical preparations. One of the variation is BOPT. BOPT, and also this BOPT has some kind of variations. In what is interesting from the BOPT concept in general is that you can really change the biotype by this type of preparation. You can change the biotype. You can create some vertical and horizontal freedom. Imagine that. So you can really transfer the thin into thick biotype. Then when you have the biologic width, violence, you can really do this technique without surgery and get a very good results for that. But you need to really learn about this kind of stuff in details. I'm not an expert in this, to be honest. I'm not an expert. That's why I invited to our team one of the most, I think, talented and also skilled and a great clinician. His name is Dr. Conti, Stefano Conti. He's one of the, how do you say, contributor in a BOPT, and also one of the inventor of the technique inside this BOPT. Okay, so I invited him to our team, so he will be a part of the BG Academy group. So he will run courses on a regular basis, as I run in our case in our academy. So that means I would trust him, but he is really great. So he has this very big vertical preparation course that will be in June, in September, and then in November. And I will be participating in this course as a student because I want to learn these tips and tricks. I have an idea about that, but the true tips and tricks, they have to be, you know, taken from the true master. And he will speak about this transformation of the biotype, how can you play with the gingival level, how you can design gingiva by the preparation, how you can deal with this periodontally involved teeth, how to deal with the temporary restorations, what kind of information you have to give to your dental technician, how can you communicate with your dental technician, because at the end of the day, if you know how to do BOPT or vertical preparations, your dental technician also has to understand that principle, and you have to guide your dental technician in which level you would like to have your temporary or final restoration. So if you're really interested in that, like I am interested, please be our guest. Come to big vertical preparation course. You can choose date, our webpage, belograd.com, and you will learn from the best, believe me. Okay, good. Let me go back. So we have another question. Another question. We have Laszlo, Dr. Laszlo. Okay, I'm going to attend your big endo resto course in August. Very good choice. I will be more than happy to see you here. Can you suggest some materials, books, or webinars for me to prepare myself of the theoretics before attending? You know, you can one of the best book about endo is by Cohen, and the name of the book is Pathway of the Pulp. So I think it's like a Bible. Okay, Pathway of the Pulp. It's a Bible. It has a lot of different editions, and that's a real Bible for endo. Also, one of my favorite books are written by Arnaldo Castellucci. He has 3 volumes, primary endo retreatment, some surgical endodontic treatments. So I would say if you have these books and you read them, that's enough to have the complete theoretical background, okay? But at the end of the day, what we have to understand that the theory, advanced theory, overloaded theory, updated theory is nothing if your hands are not stable and you don't know what to do properly. So if you already booked our course and the rest, let me just show this course to other people, so maybe somebody would like to join it also. You'll have enough. From the clinical perspective, from the hands-on perspective, that's more than enough. With these 2 days, you will have everything. You will have primary endo, isolation, access, instrumentation principles, strategies, protocols, depending on the difficulty of the root canal. Easy, difficult, very difficult. Irrigation protocols, okay? Then obturation techniques. Then, which is really a keystone of the course, is the restorative driven endos. You will understand how to restore the teeth after endodontic treatment, and do you really need to do endo, or maybe you have to go for the alternatives. So you will have the true understanding about proper treatment planning in endo cases. And the second day is a retreatment. So we will teach you how to remove fiber posts from the root canal, how to remove buildup from the tooth, how to remove gutta percha, how to retrieve a broken file from the root canal, then how to make a buildup, how to prep tooth for the overlay, how to do fiber post and core, and prep the tooth for the crown. And that's not a joke. You will do preparations during the endo course. You will prep tooth for the overlay, and you will prep tooth for the crown. That's completely hands-on, 100%. Only hands-on. So to read these books, to get some background, theoretical background, but the most important in endo, at the end of the day, it's practice, okay? It's practice, the protocols, and so on and so on. And this is what we will give you during the course, and that will be more than enough for you. And then you will practice on your patients following these rules, protocols, and you will become a very happy person in endo. For other people, we will be also more than happy to see you during our endodontic, it's not endo course, it's an endo resto course. It's a real mixed fight. It's a real combination and a synergy between endodontics and the restoration in one hands-on course out of others. I would say that's a unique course because really it's really practical oriented, and will teach you everything in that field. Okay, let me check what else we have here from the questions. Could you please tell me how you isolate composite build-ups? Cobra Karen, that's the question from our colleague from Kiev. Привет. Composite build-ups or dentin after performing IDS to prevent temporary materials from sticking. Do you use something like Rondoflex? It depends on the type of the provisional that you are going to do. If you do provisional crown or provisional overlay, then before I will use silicone index, and I will fill it with a bisacrylic. I will cover teeth with a glycerin gel. Okay, so I put glycerin gel, just air thin it. Then I use my silicone index. I put their bisacrylic. I go wait, and I take it out clean, and then I will use a temporary cement. So this temporary cement will prevent sticking of the provisional restoration to this fresh composite or IDS. Another thing which you also have to do is you take alcohol, okay, with a cotton pellet, and you wipe this IDS zone with the alcohol, because it will help you to remove this superficial monomer. But glycerin is mandatory. That's important. Okay, let's go back. What do you think about Endocrown? Cobra Karen, that's a question from him. Endocrown is good. It's a good option. The only thing I don't like with the Endocrown is that if you will need to do a conservative retreatment, then you will have a lot of fun to drill the Endocrown out. So personally, I do not use Endocrowns, not because I will do all retreatments of all my cases, but then I would like to use I prefer to use light curable composite. Okay, light curable composite. But if it is Endocrown, we have to go for the dual cure. I'm not saying that dual cure is bad, but it limits me in time. So I would like to build up. So by building up, I can decrease the thickness of the restoration till optimal. The optimal thickness is up to 2.5 millimeters. Okay, so if the restoration is thinner than 2.5, you can light cure through. If it's thicker, then you go with a dual cure cement. Okay, good, perfect. Yeah, so Benan comments that the 12th edition of the Pathway of the Pulp is the best. Completely agree. Good. Another question from Instagram. We have start full mouth rehabilitation for beginners, and how would you start learning more about function and occlusion? That's another question from another participant. And again, occlusion is like a religion. You have to know in which church to go, okay, or mosque. So what you will have to do, definitely books, but then you have to understand which one to go for, Dosen, Slavicek, or Occlusion, or so on and so on. I can tell you about myself, okay, if you don't mind, because I came to the necessity to master function and occlusion when I started to do a lot of aesthetic cases. I was okay with the preps, with the scans, with impressions, with bonding. Everything worked perfect. I used the Facebook. I knew what is CR. I had articulator. So basically, I was more or less advanced, let's say. But the thing is that sometimes I got some problems with my cases, like a chipping, fractures, and something like this. And then I started to realize that something is wrong with my protocol. Something is wrong with my knowledge and skills in more complex cases. So what I did, I went to some lectures and conference about that. It was complicated, to be honest, because when you have the lecture or conference, there are short lectures and they are not giving you the whole understanding of the occlusion, which is impossible. I mean, to understand occlusion during one lecture. You have to learn about occlusion whole of your life, to be honest. Then I read books. I got the book from Dosen. Also, I read the book from Rudolf Slavicek, very complicated. It was like a book causing the brain cancer. Really complicated, okay? And I understood nothing. And then what I did, I went to like an office course, 2 or 3 days, I don't remember how much it was, when there was a live patient, you know, the dentist doing all this functional diagnostics, treatment planning, and then after that, I started to realize something, but it was not enough still, but I really understood in which direction I need to go. And then I went to the advanced curriculum about function and occlusion in the Vienna school. So it's like a 1.5 years of program about occlusion and function. So being a beginner, I would suggest to start with a course, like an office course, okay? It's not because I want you to advertise our course. It's because, yeah, I want to advertise our course. We have a very good course about function and occlusion, like diagnostic and treatment planning, full mouth rehabilitations, differentiation, easy cases, difficult cases, protocols, how to do your easy full mouth rehabilitation case step by step, and you'll be able to see all these steps, digital and analog, live, on a live patient. But the thing is that when you are in this environment, when you see clinical steps, you have speakers, you have other colleagues, you ask, you interact, you know, the information that you will absorb is a bit different comparing to the books, because when you read the books you cannot understand something and then you just skip it and you go here. When you don't understand something, you can ask, you can see, you can actually feel how it goes, and so on and so on. So this kind of course that we offer will give you a good protocol for the functional diagnostics and the treatment planning for the patients, and differentiations cases by the level of complexity. And then what is also very good from this program is that you will understand in which direction you will go. Or maybe you will say, okay, that's too much for me, it's very complicated, I would better do endo. And that's a good option because, you know, because to be honest, when you go into the function, the occlusion, full mouth rehabilitation, that's next level of dentistry, and that's next level of the studies, next level of equipment, next level of timing, and next level of responsibility. So sometimes it's really good to understand if it's yours or not. But if you will understand that this is yours, then the world will open for you. And by the way, after this program, you will look at your patients from the different perspective. You will see yourself before and after, like two different dentists. So you can see dates, you can see our webpage, and you can go to our course with no regret. Okay, my friends, I was happy to talk to you, to spend this evening. I would like to wish you all success in dentistry. We will keep this live stream on our YouTube channel, so you can always review it. I would kindly ask you to follow us on YouTube if you didn't follow us yet. So please sign up, be our follower, be our guest, and share this live stream also with your colleagues, because I think that we shared with you some nice clinical tips and tricks that will help to you and to your colleagues to become better in dentistry. And I would like to thank you for your kind attention, and may the dental force be with you. See you next time.